Welcome to Nephrology Ground Rounds this sunny Friday. We have a morning of nephrology pathology conference today. Looking forward to it, and I'll let you take it away.
Okay. Yeah. Good morning, everyone, and thanks for joining, and thanks for giving us the opportunity to take the whole 1.5 hours. I hope that it won't be boring for you guys. So we have 3 cases to present today, and without further ado, I would like to start. The first case, actually, it's going to be the clinical part. It's going to be presented by Dr. Carly. I don't know if Dr. Carly has joined or not.
I'm on. I don't know if you can hear me.
Okay. Yes. Yeah.
Okay,
yeah.
great.
I can perfectly. I can hear you.
Perfect.
So if you would like, we can start.
Sure. So this is a 48-year-old guy with history of alcohol use, cirrhosis, high blood pressure. He was admitted with a 3-day history of weakness, poor appetite, body aches, fatigue. He also had decreased urine output for the same 3 days and started having some nausea and vomiting the day prior to presentation. Before this, no known renal issues, wasn't using a bunch of NSAIDs. He was just on hydrochlorothiazide and benazepril, which he actually self-DC'd before he came because his blood pressures were so low, and no known allergies. So on vitals, not too bad. Blood pressure 126/99, pulse 84, afebrile. Exam was fairly unremarkable, except some evidence of liver disease with the fluid wave, some icterus, and a little bit of swelling in his legs, as well as some jaundice. So you can see his labs were remarkable: sodium 117, potassium 1.5, chloride 65, creatinine 10.19. You can see some evidence of liver disease as well. And renal ultrasound was not too impressive, pretty normal, good sized kidneys. So because of these electrolyte abnormalities, he was admitted to the ICU, and his electrolytes did improve with some fluid and repletion. Renal was consulted on day 3, and we started dialysis because his kidney function continued to worsen, and he started to develop some early uremic symptoms like fatigue and nausea, some confusion. We got some GN serologies, not all of which were resulted by the time the biopsy was done, but essentially they were normal or negative. Of note, his urine protein was, protein creatinine ratio was 45 grams. So we empirically started him on some high-dose steroids while we were waiting the biopsy. I think those steroids were started like on a Saturday, and the biopsy was done on a Monday.
Okay, so thank you very much, Dr. Carly, for the clinical history. Questions for Dr. Carly? And if you would like to start putting in the chat box, what are your differentials, or you can just say.
So it's 4.5 grams, so 45 grams of protein. And then the second question
45.
is 45. And then was there any hematuria?
There was hematuria, yes. Just supposedly trace amounts.
Questions? Let me see. Okay, so in the chat box, we have MPGN, IgA nephropathy, IgA dominant MPGN. So we have 2 differentials and the combination of both. Let me see, is there could be IgA dominant or IgG dominant? Okay. Any other thing? Okay, so I will go on with the biopsy, and we will have more questions as well. Let me see if ethanol more likely IgA dominant. Okay, all right. So let's keep going. Okay, So this is the low magnification of the biopsy. It was a very nice biopsy with including both cortex and medulla. But I mean, just with this low magnification, obviously, this does not look normal. I mean, you look at it, it just, there are numerous holes, large holes in the biopsy core. You get a feeling that maybe the tissue is falling apart. 17 to 20 glomeruli per level section, very nice sample. Not much chronic injury, 1 to 2 glomeruli were globally sclerosed. And as you can see, in the cortical part also, the tubules mostly are back to back, but they're not normal. So the next question is that, what are you seeing in this picture? This is a little bit higher magnification view of the tubules. And the choices are acute tubular injury, light chain cast nephropathy, tubular interstitial nephritis, light chain proximal tubulopathy, and oxalate nephropathy. I could have included something else to cover for the rest. So acute tubular injury, acute tubular injuries, I can see that most people are favoring that we're seeing acute tubular injury. Okay, very nice. So indeed, let's see, this is a little bit higher mag. Let's go back. That's correct. We have acute tubular injury. It's a very widespread and severe acute tubular injury. I have to confess that this is one of the most severe acute tubular injuries, or ATNs, that I've ever seen. So basically, the tubular epithelial cells, virtually you feel like they are falling apart. And they have very weird appearance as well, with these vacuoles. Many areas they're flattened with loss of brush borders, as I've shown here. Different changes in relation to acute tubular injury can be seen. The very common changes, flattening of tubular epithelial cells, brush borders are completely lost. But also there is something peculiar about this, and that's presence of these large cytoplasmic vacuoles that as you're seeing, multiple cells, sometimes in a row, are affected by that. And the question is that, what are these, and are there anything in them? And I have to say that this is an H&E stain, and H&E stain is a good one to pick up crystals, and there were no crystals in the tubular epithelial cells and in those vacuoles. This is another picture, and again, as you can see, this is Jones methenamine silver. The proximal tubules, they show these vacuoles. They are tremendously large. It looks like, I mean, the cells, one cell can have a very huge one. They're in different size. They're not quite regular. And here is another picture of the same thing over and over again. Looking at the glomeruli, by light microscopy, the glomeruli were pretty much unremarkable, not much going on. And of course, in the surrounding tubules, you see sloughing of the tubular epithelial cells. And again, these very large, humongous vacuoles in the tubular epithelial cells. But interestingly, besides all of these huge vacuoles in the tubular epithelial cells, other structures also showed vacuoles. So what are we seeing here in the box with dashed green? If you want to put in the chat box, what is that structure? Is the proximal tubule? Is it the distal tubule? Is it a vein? Is it an artery or arteriole? Is it a parasite? Something else? Part of interstitium? PCT, interstitium? Those are the answers in the chat box. Any other idea? Okay, so by PCT, I suppose that's peritubular capillary, maybe PTC, or proximal tubular cell. I don't know which one is that, but actually, I mean, this is, as you can see, we have some red blood cells, we have flat cells that are endothelial cells. This is an arterial. This is an arterial, but this arterial, as you can see, shows prominent vacuolization of the smooth muscle cells in the arterial wall. So, and interestingly, that finding was quite diffuse. And I took pictures of every single arteriole that I found in that biopsy. And these are representative images of those. As you can see, I mean, pretty much all of them, they show these prominent vacuoles. Vacuolization of the arterial smooth muscle cells, sometimes we see in the biopsies and we can't link it to anything. But in this case, I have to say that it was particularly prominent. Every single arteriole that we were looking at basically was showing these vacuolization. Now let's look at the immunofluorescence microscopy. And so by immunofluorescence, there was relatively modest, I rated as 1 to 2 plus C3 staining in the mesangium. That we thought that, okay, I mean, is there anything related to infection or something else going on? But as I showed you, there was no prominent proliferative changes or inflammatory infiltrate in the light microscopy. And also by electron microscopy, there were no immune type deposits. So that was kind of like an isolated finding that may be related actually to the clinical history, and one subtle finding that I will show you by electron microscopy. So by electron microscopy, what we have, the endothelial cells, you can see the fenestrations. Some people call this honeycombing pattern. In some areas more prominent, in some areas we see the fenestrations are lost. Food processes, they are segmentally effaced. They are not quite basically widespread in terms of effacement, segmentally effaced. Nothing that matches with that huge amount of proteinuria to say that, okay, I mean, this is enough to call it a concomitant primary podocytopathy. Also, peculiarly, another thing that we had was the presence of these vacuoles in the mesangial cells. That was another interesting finding. So these are mesangial cells, as you can see, and also a little bit of loosening of the mesangial matrix. Again, in the other mesangial cells that I'm showing, we're seeing vacuoles reminiscent of what we saw in the arterial smooth muscle cells. There is another subtle findings here as well. So as you can see, slight loosening of the mesangial matrix, as I said, and if we magnify, we see that there are these little granules that are partially electron dense, round, partially electron lucent, which is typical or characteristic of lipoprotein granules. That we can see in association with hepatic glomerulopathy. So maybe a very modest early stages of hepatic glomerulopathy is observed over there. By electron microscopy also, we were able to document the same findings by light microscopy in the proximal tubule. So this is a proximal tubule, and as you can see, there are these huge vacuoles inside the tubular epithelial cells. Again, here, as you can see, we see these prominent vacuoles and loss of brush borders. It's a proximal tubules, and as you can see, pretty much has lost all of the brush borders as well as this one. Again, here we're seeing these vacuoles. It looks like there are multiple tubular epithelial cells that, you know, they are affected by this process. Okay, so what is the diagnosis? How we interpreted these findings? Severe widespread acute tubular injury, as all of you said, but with features that are strongly suggestive of hypokalemic nephropathy or hypokalemic acute tubular necrosis or acute tubular injury. And the other finding that I showed you, arterial smooth muscle cell vacuolization, is also another finding that has been well recognized in association with hypokalemic nephropathy. Indeed, vacuolization in other cell types, such as podocytes, has also been described that we did not see in this biopsy, but instead we saw those vacuoles in the mesangial cells that, as far as I know, have not been reported in the past. So what about the C3 staining? There was modest C3 staining in the mesangium. We didn't find any electron dense deposits. We didn't find any active glomerulonephritis, but it might be related to the presence of very modest and early stages of hepatic glomerulopathy. In hepatic glomerulopathy, we can see modest C3 staining in the glomeruli. That is well known. In terms of presence of significant protein creatinine ratio, we saw evidence for podocyte injury, but not basically in the magnitude to call it a separate diagnosis of primary podocytopathy. So hypokalemia-associated ATI was first described in 1950 by Perkins, and the term, some other terms have been used to describe this entity, like kaleopenic nephropathy that have been described by Kahn and Johnson, and also hypokalemic nephropathy, which is more common terminology used for that by Kramer and Buck in 1977. And there are multiple biopsy reports in relation to these as well. The key features are large vacuoles, primarily involving proximal tubules, but it can also involve distal tubules. Has been described, the vacuoles have been described in tubular basement membranes. We did not observe that in this biopsy. Arterial smooth muscle cells, we saw podocytes, we did not see, and mesangial cells that has not been described in the past, but it seems like we can see that based on the biopsy findings that we have here. I've listed here some of the differential diagnoses, and I say that some of them because presence of vacuoles in the tubular epithelial cell cytoplasm is not a rare finding, but the common ones are listed here. ATI, I call it ATI-NOS, the kind of ATI that we see all the time in association with ischemia or in association with toxic material, but with no specific toxic material, such as the ones that are associated with the specific crystals and so on and so forth. These vacuoles are irregular in size and distribution. Calcineurin inhibitor toxicity, we call it isometric vacuolization. The vacuoles are very small, are very regular. Osmotic nephrosis, where we see hydropic changes in the tubular epithelial cells in association with hypertonic solution or SGLT2 inhibitor. Hypokalemic nephropathy, of course, the one that we just looked at. Fabry nephropathy, that the vacuolization is distinctly limited to the distal tubules, and of course other cell types, podocytes, very prominent that they show vacuolization, and it's more heterogeneous. Other types of vacuolization in the tubular epithelial, such as Armani-Epstein, that is more rare these days, have also can also be included in this differential. The mechanisms are not well known. The ones that have been proposed include intracellular acidosis, increased ammonium production inside the cell, leading to cellular injury, electrolyte-mediated fluid shift in subcellular compartments, and dysregulation of autophagy. But I have to say, I mean, these the vacuoles, they do not look like autophagosomes at all, but whether dysregulation of autophagy is playing part in this or not is not well known. Dr. Colley, do you have any follow-up for these patients? And then if others have questions.
He was started on dialysis on January 26th, and he's still on it today.
Oh.
Yeah.
No improvement.
Did he have any DI? I mean, it's hard to know because he was drinking a lot of alcohol, but did he any complain of any muscle weakness or had anything in the history that would point towards nephrogenic diabetes insipidus from hypokalemia?
He did have some generalized weakness for about 3 days before, but otherwise nothing else super profound.
So that was the proteinuria was really 45 grams per gram, or was that a 24-hour 45 grams?
It was a spot.
A spot?
Yeah.
Was there anything in the biopsy that suggested why there was such profound proteinuria?
So I would say that if I want to propose something, that would be two. One, there was evidence for podocyte injury, and as I said, hypokalemia can basically lead to injury of all different cell types. And I showed you like a Smith muscle cells. I showed you the tubular. Of course, the tubules are the most prominent one, but podocytes as well. Vascularization has been reported. Nephrotic range proteinuria has been reported, and we saw food process effacement. It wasn't quite widespread, but on the other hand, you have to consider that you have the other side of the glomerular filtration barrier completely screwed up as well. So those tubules with that much acute tubular injury, how much reabsorption they can do. So if I want to propose something, that would be a combination of both of these things. So we have podocyte injury. On the other hand, we have very severe acute tubular injury and compromisation of the tubular uptake of albumin and proteins.
Okay, thank you. And I see Dr. Pitchler's comment. Thank you. So you wouldn't trust that number anyway. Okay.
Okay, any other questions? In the comment, let me go over the comments and see. Accumulation of lipoprotein X, as I said, yeah, there was evidence for very mild hepatic glomerulopathy, very modest. Any history of a storage disease, I'm not aware of. If Dr. Carly, you're aware of any history of a storage disease, what kind of a storage disease you had in mind? And then there is another question: what caused his metabolic alkalosis? I don't know if the patient had vomiting or something. Or,
what's interesting about him, he presented with severe acute kidney injury and had a significant metabolic alkalosis, which I thought was interesting. Maybe he was just vomiting a lot, but it was interesting.
He did have some nausea and vomiting for about the day prior.
I mean, if he's having a lot of ammoniogenesis, that can explain. It's like as the ammonia is getting excreted through the proximal tubule, there'll be more bicarb absorption.
Yeah, and also there is a comment that with low urine creatinine excretion, PCR in gram per gram could markedly overestimate protein excretion in gram per day. The units are key. That I agree. Okay. If there are no other questions or comments, we can move to the second case. I think that Dr. Maeda wanted to start the second case because she wants to leave early. Is that correct? You want?
Oh, we can wait or whatever works.
Okay, if that's okay with you, we can switch back and forth. There's no problem with that. But if it will be smoother if I continue.
Yeah, that's great.
Yeah.
Okay, perfect. So let me get out of this and start with this one. Well, thank you very much, Dr. Carly. I know that you were very busy and graciously agreed to present this case.
I think if you can swap your screens, but there you go.
Okay, so the second case is acute kidney injury following PBSD, and the clinical discussant is Dr. Sarah Sangav. Sarah?
Yeah, hi everyone, good morning. So this is a case of a 60-year-old gentleman who has hypertension. He has a positive JAK2 myelofibrosis. actually got diagnosed when he was noted to have a large spleen. And once they took out the spleen, they found that he had significant extramedullary hematopoiesis. So he comes in for an allogeneic unrelated peripheral blood stem cell transplant. He received conditioning with melphalan, fludarabine, and 300 centigrade total body irradiation. And this was a myeloablative reduced intensity conditioning regimen, likely because she's just on the cusp at the age of 60 for more intensive therapy. He received his cells and was started on cyclosporin 400 milligrams twice a day, mycophenolate 1,000 milligrams twice a day, and sirolimus 1 milligram per day. He developed really bad mucositis and was started on TPN the next day. And ultimately, his cyclosporin meds were changed around and titrated up to 400 milligrams daily. And then on day 12, post-stem cell transplant, his sirolimus was discontinued because he had a rising creatinine. And that's when the nephrology team got involved. Oh, I did not realize I had animations here. Okay, there we go. So on history and physical, he was net positive 11 liters. A POCA stun at the time showed a large IVC with less than 50% respiratory variation. He had positive B lines on his lung exam and a left pleural effusion. So really evidence of tissue edema and intravascular volume expansion. He had not been taking any NSAIDs. His urine sediment said no cast or cells per the consult note at the time. He also had some extra labs and procedures done. So he had 1+ cysticytes on his peripheral smear. His LDH was relatively normal at 250 to 310, and his haptoglobin was high. Calcium was normal. And then he had an echocardiogram. And this was day 2. So this was 2 days before his creatinine started rising. But it showed a normal ejection fraction. He did have a bicuspid aortic valve with just mild aortic stenosis. So at this point, he was diuresed 6 liters until he reached euvolemia. The oncology team held a cyclosporin for days 15 and 16, restarted on day 17. His creatinine peaked at 3.2 on day 18. And actually it improved. And let's see
I
what.
think that the biopsy was done on day 19. That's why. So the creatinine was improved a little bit before the biopsies.
Actually, no. So there's I think there's a little discrepancy there. So his creatinine went back down to 2.5. I'm not sure if you have that next slide, Bazad.
No.
Okay, so his creatinine actually improved down to 2.5. Renal team signed off. Everyone was happy. ATN recovered. And it was only after it abruptly rose again. So this time his creatinine rose to 3.9. And at that point, the biopsy was performed.
Okay. All right. So before going to the biopsy, questions for Dr. Sanghavi and differentials on the chat box, or just say.
A cyclosporin level was checked. I actually had a nice chart of it, but it doesn't seem to have made it in. But I think I have my PowerPoint. If you'll give me a second, I'll give you those numbers. So on the second AKI, his cyclosporin levels ranged from 160 to a peak of 311. So not much higher than that. The team was trying to keep them relatively low, given that he had developed this acute kidney injury.
Okay, so Dr. Jeffers.
And then Abal asks, did he have proteinuria and hematuria? No proteinuria or hematuria. And then Ashley's trying to give stuff away.
Yes, yeah. So okay, so let's look at the biopsy. So
I'm just going to answer Abal's
say
question.
something? Okay,
Oh yeah, so Abal just asked if there was any infection. He had no infections at this time.
Okay, thank you. So again, very nice biopsy with 2 cores, including cortex and also the medullary portion. Let me try to get laser pointer here. Yeah. With approximately 20 to 37 glomeruli per level section. And again, similar to the prior biopsy, not much chronic injury. As you can see, the tubules mostly are back to back. There's focal chronicity, focal inflammation, but on this low magnification, when you look at this, it's there are some abnormalities. I have to say that not as impressive as the prior one, but definitely does not look normal to me. I don't know if it does to you. So let's look a little bit closer. And we start with the same question and actually the same answers. Acute tubular injury, what do you see? Light chain cast nephropathy, tubular interstitial nephritis, light chain proximal tubulopathy, oxalate nephropathy. Okay, I don't see anything in the chat box. So I continue. So similar to the prior biopsy in terms of presence of acute tubular injury, we see that here as well. I mean, the more prominently we can see here in the lumina of these tubules that, yeah, there are these sloughed tubular epithelial cells or portions of tubular epithelial cells. And also similar to what we had in the prior biopsy, also we have flattening of tubular epithelial cells and loss of brush borders. There is some vacuolization of the tubular epithelial cells here and there as well. I like this slide because it's actually, you can see different kind of tubules in terms of morphology. So here we have a tubular profile that is more on the normal side. You can recognize this is a PS stain, right? So you can see the tubular base and membranes very nicely, and you're supposed to see brush borders better. So you can see a relatively thick brush borders. So if all the tubules are like that, we call it normal. But also we have acute tubular injury with flattening of tubular epithelial cells, as you can see, complete loss of brush borders. And also we have cytoplasmic vacuolization, as I showed you in the prior picture. And also we have atrophic tubules with thickening of tubular base and membranes and corrugation of tubular base and membranes as well. Okay, so this is a Jones methylamine silver. And with Jones and H&E, you can appreciate the type of changes that we see in the tubules a little bit better. So as you can see, there is patchy involvement of tubular epithelial cells. And in contrast to the prior case of hypokalemic nephropathy, with those huge vacuoles, here we have regular vacuoles, very fine. They're pretty much of the same size. I haven't measured them. So if one wants to call them isometric vacuolization, as Dr. Jefferson mentioned, I think that that would fit nicely here. Again, here you can see these patches of tubular epithelial cells with all these fine and nice vacuoles. This is a high magnification of one of the tubular epithelial cells. And as you can see, it's very beautifully involving proximal tubular cells as well as distal tubular epithelial cells, some of those. So again, here is another picture, very typical for isometric vacuolization in both proximal tubular epithelial cells as well as distal tubular epithelial cells. These changes can be seen. In the interstitium, I have to say that mostly we see edema, although this is not the best stain to, which is H&E, not the best stain to interpret the fibrosis, but it doesn't look dense like these areas. Mostly it's edematous. Glomeruli were pretty much unremarkable by light microscopy, no proliferative changes, no obvious thrombotic microangiopathy in the glomeruli. This is a renal vein, and adjacent to renal vein, we had eosinophilic aggregate. But this was a finding that was limited to this area, and we did not observe that in other locations. Vascular changes in other parts, we have arteriosclerosis, and this is an arcuate artery, as you can see, runs between cortex and medulla, and arteriosclerosis is kind of like moderate or mild to moderate in this vessel. And the other vessels, this is an interlobular artery. As you can see, the media is beautifully visible, and many of them no obvious hyalinosis, and also no obvious thrombotic microangiopathy in the arteries and arterioles. However, focally, we had hyalinosis involving arterioles. And as you can see in this one, so this is the lumen, these are the endothelial cells, this is the media, and the hyalinosis was subendothelial, although in this one, as you can see, it's almost concentric. But we did not find instances of adventitial nodules, which would mean that you see hyaline out here touching the adventitia, which means you have a smooth muscle cell injury. In terms of chronic injury, as I told you, it was focal. It was the area with chronic injury. And these are a couple of, the artery or small interlobular artery with some hyalinosis that, again, it's subendothelial. And acute tubular injury is evident and is present pretty much in the whole cortex. Interestingly, although we did not have obvious thrombotic microangiopathy in the glomeruli or in the arteries, but in some of the peritubular capillaries, we had very significant congestion. We also had influx of inflammatory cells. And here is structure that was probably in a vasa recta. It was not quite clear. We had this pinkish material that basically raised concern for presence of a thrombus in probably a vasa recta, but it's difficult to identify this structure. One cannot be quite sure about that. So the final diagnosis is acute tubular injury, widespread with patchy isometric vascularization, as Ashley mentioned, and focal capillary vasa recta, thrombi in the medulla, with raising concern for prothrombotic condition, but we did not identify thrombotic microangiopathy in the glomeruli or in the vessels. I have to mention that we were limited in our assessments because there were no specimens for immunofluorescence or for electron microscopy. So I can't make any comment if at ultrastructural level there was evidence for endothelial damage in this case. And chronicity was of course mild. So yeah, you would think that these changes, based on the clinical history that was provided, was related to calcineurin inhibitor toxicity. There are various mechanisms. I've put a red box around the different lesions that we see in association with calcineurin inhibitor toxicity. There are both acute lesions as well as chronic lesions with various mechanisms, from causing prothrombotic conditions to vasoconstrictive and hemodynamic changes that are believed are common. If you do a biopsy, you don't see anything, or inflammatory changes and also vascular changes that in time they lead to chronic injury, tubular interstitial fibrosis in a striped pattern, arterial hyalinosis, as I mentioned, especially if it's there are adventitial nodules, chronic changes in the glomeruli, from FSGS to global glomerulosclerosis to itubular glomeruli, and of course isometric vascularizations, as we saw, and some hint for prothrombotic condition and TMA. But the changes, the morphologic features of calcineurin inhibitor toxicity that were characterized initially and most prominently by Michael Mihaj. We have to consider that I put this editorial that was written actually by Michael Mengel, Mihaj, and Phil Halloran, that we have to consider that for calcium inhibitor toxicity, there is no such thing as a specificity. And that has been shown in fact, in blind assessment of features that we attribute to calcium inhibitor toxicities. Yeah, it's definitely you have to put it in the context, because in the past, many of the findings especially in the transplant biopsies, kidney transplant biopsies, were being attributed to calcium inhibitor toxicity, similar to diagnosis of CAN for those of us who remember those days, chronic allograft nephropathy, which was like a wastebasket. So, so definitely we have to put it in the context, because there are also many other mechanisms of injury to the kidney after like a stem cell transplant or bone marrow transplant, as outlined nicely by Dr. Sangeeta Hingorani. So from endothelial damage to tubular interstitial injury, GVHD, and so on and so forth. So we have to consider those mechanisms as well, and put everything in the context to reach to a meaningful interpretation of the biopsy findings. Okay, questions for me? Follow-up from Sarah, do you have any follow-up from this?
Yeah, I'm just going to read off Dr. Blosser's comments because I think it's a good one for everyone to hear. So it's a more common finding and explanation for AKI in patients treated with a CNI and mTOR inhibitor, specifically heart transplants and stem cell transplant recipients, which require the same P450 enzymes for metabolism, thereby prolonging higher serum drug levels, resulting in adverse events, including CNI injury. And that's what, this patient also was both on a CNI and sirolimus at the same time. The follow-up, unfortunately, is that the patient had multiple problems, including aspergillus of the lung, Enterobacter bacteremia, GVHD of the gut, and then finally Candida glabrata bacteremia, and subsequently passed away.
Oh, very sorry to hear that.
I could add something to Chris's comment too, is that the mTOR inhibitors are also going to be inhibiting repair. So in general, acute tubular injury or any type of injury in the setting of someone taking an mTOR inhibitor is not a good thing. So that repair process is likely to be delayed by that drug as well, also contributing to, say, exacerbation of injury.
Yeah, and I'll mention that in terms of his kidney specifically, he did recover slowly from the second bout of AKI, but subsequently had 2 more episodes of acute kidney injury, one related to just severe volume depletion when he developed GVHD of the gut. And then the second, at that point, who knows? And about a week before he passed, he was started on dialysis.
Okay. Any other questions, comments? Okay, so if there is none, I stop sharing, and you on?
Yes, I'm gonna start sharing my screen. Can you see my screen now?
Yes.
Okay, perfect. Thank you. So Michelle, are you?
Yeah, I'm on.
Okay, could you please start with the clinical information?
Sure. So this was a patient we saw in consults. She was a 71-year-old female who had a history of metastatic endometrial cancer that got admitted for an AKI. So next point. So she was somebody who had very stable kidney function. Her baseline creatinine was 0.8 to 0.9. And was doing fairly well, and then got routine labs in the setting of kind of surveillance for her cancer on March 2nd, and her creatinine was up to 9.26. as we talked to her, kind of the history that we got, at least for her cancer, was that she has been in this phase 2 clinical trial with this drug, temimostat, which was a small molecule inhibitor of ECH2. And she had been on that from December 2022 to just February 21st of this year, and then had to stop it because of diarrhea. And talking to her, she was having 5 to 6 stools daily for about 2 months last year when she was on the medication. And that actually improved after stopping the medication and starting a brat diet. And the other thing that we found from her that had been going on recently was that she was having some UTI symptoms, and her doctor was treating her for that. So she was on a course of macrobid, 100 milligrams BID for 5 days, and then Cipro, 500 milligrams BID for 5 days, because she was still having persistent symptoms. And then she otherwise felt fine when we saw her. She had a negative review of systems, and otherwise, besides the lab abnormality, she wouldn't have otherwise come into the hospital. And this picture here from Epic kind of shows her trend of her creatinine. So she actually had labs checked just 11 days before. And as you can see, her creatinine was normal in her baseline range, and then just all of a sudden jumped up to 9.26. Next slide. So this is kind of her other history. She also had a history of diabetes besides the endometrial cancer, hypothyroidism, hypertension, depression, and GERD. Other medications that she was on is listed, including amlodipine, atorvastatin, Pepcid, Flonase, gabapentin, levothyroxine, lisinopril, loperamide, Tradjenta, and she denied any NSAID or over-the-counter supplements. And as for her oncologic history, that's listed on the right side here. So she was diagnosed with endometrial cancer in 2020 after presenting for postmenopausal bleeding. She had surgery the same year and also underwent brachytherapy. And then she's been on different courses of chemo and immunotherapy, including paclitaxel and carboplatin in 2021, another experimental medication that same year. And then from November 2021 to October 2022 was on lenvatinib and pembrolizumab. And then, like I said, most recently, she has been on this research trial on temimostat. This was her workup. So blood pressure was a little bit elevated at 147/69, but the rest of her vitals were okay. She appeared in no distress, had moist mucous membranes, and the rest of her exam was really unremarkable. Her UA showed trace protein, 11 to 20 white blood cells, and 3 to 5 red blood cells. And when we performed urine microscopy, we again saw white blood cells, isomorphic red blood cells, no cast or crystals or anything. Her urine protein creatinine ratio was 0.3, and urine albumin creatinine ratio was 94 milligrams per gram. And we did kind of an extensive workup for her. She got complements that were normal, ANA and ANCA that were negative, LDH, haptoglobin, CK, those were unremarkable. And she also got a renal ultrasound that showed increased echogenicity, but was otherwise unremarkable. And she had gotten a CT abdomen pelvis without contrast just a few days before that didn't show any evidence of mets or invasion into her urinary system. And on the right, was just her initial labs on presentation. Okay. So our differential for her was very wide. We were kind of combing through her history, especially given kind of her multiple chemo immunotherapy medications. Initially, we were thinking pre-renal cause given this history of diarrhea, but it sounded like it was more remote and the diarrhea had slowed down and her AKI didn't improve with fluids. We thought ATI, there no obvious history, and our UA didn't show any granular cast. And then, of course, AIN, given kind of different medications that she was on. Initially, we were thinking about the pembrolizumab, but that was a few months ago, and her creatinine had been very stable afterwards, and it was just very acute of an increase that didn't seem to fit the time course of an AIN. And then more recently, she was on Cipro, and so we thought about that causing an AIN, but again, the timing or the time course of this abrupt rise in creatinine didn't really fit the course. We did see white blood cells on her UA, so we had thought about steroids or treating her empirically with steroids for AIN, but ultimately, given we didn't really have a good explanation for why she would have AIN, we decided to hold off and wait for the biopsy. And so given the overall uncertainty of her diagnosis, a biopsy was performed.
Okay, thank you. And this is what we get. So this is the H&E staining. We have a very nice core with both cortex and medulla. Actually, medulla is the larger portion, like a little bit cortex here. And we have 3 to 4 glomeruli per level section. And none of them is globally sclerosed. I'm going to show some higher magnification of the biopsy core. So this is a field showing acute tubular injury. Well, you can see the attenuation of the tubular epithelium, and also here is a mitotic figure, dilatation of the lumen as well. So there is evidence of acute tubular injury. And more over it's when we look really, really carefully and into the biopsy, we can see those. So the green arrow is pointing to these pimpleish, purplish crystals, and the double arrow is pointing to those cell reactions, kind of a giant cell reaction surrounding these crystals. It's very rare. This is maybe one of the 1 or 2 foci we saw on the entire biopsy core. And then when we look at these crystals under polarized microscopy, it's actually polarizable. So here again, it's pointing to this tiny crystal here, and then this is this giant cell reaction surrounding that crystal. So in some other area, we could see a few scattered eosinophils. It's mainly in the medullary parenchyma. Here again, some eosinophils. An interesting finding in the medulla is that we see some interstitial hemorrhage, and then at the edge of the biopsy, it's kind of a collection of fibroblasts. We're not sure what exactly it is, but here again, from the same focus, H&E staining, we have the interstitial hemorrhage, and then here again from that same focus. So there is very patchy from the sample cortex, very patchy IFTA, tubular atrophy, and interstitial fibrosis. The glomeruli, they look pretty unremarkable. Here again is a high magnification of the glomerulus. It looks pretty normal. And then the arterial here is actually showing some hyalinosis. The arterial hyalinosis again from a different focus. So IM finding is negative. We don't see any immune complex mediated process, and for EM, there is some remodeling changes of the glomerular basement membrane, the capillary loop here, and the overlying podocyte. They have some food process effacement. Other than that, we don't see immune complex deposition or electron dense immune type deposits. So for the tubules, there is some enlargement or basolateral enfoldings, but otherwise we don't, the brush border is still well preserved, and otherwise we don't really see crystalline material within the tubular lumen or within the tubules. So the final diagnosis was there was acute tubular injury and mild tubular interstitial nephritis with focal crystalline material. There's very focal tubular atrophy and interstitial fibrosis, mild arterial halitosis. So we were thinking those focal crystalline material is related to the ciprofloxacin exposure, the so-called ciprofloxacin-induced crystal nephropathy. So it has been reported before the ciprofloxacin crystal nephropathy. It was hypothesized that it can precipitate when the pH is less acidic and closer to neutral, and also correction of the pH and fluids can probably start clearing the crystals. So that's why it's very challenging to find these crystals in the biopsy. As I showed previously, that small focus of crystals is probably the only 1 or 2 foci we found in the entire biopsy. So it's very rare. So what's the difference if you compare to the more commonly seen calcium phosphate crystals and the calcium oxalate crystals? So this is the image. So the panel A is showing the abundant basophilic calcium phosphate crystals, and it's positive for the von Colza staining on the right. And for image C, it's showing the translucent calcium oxalate crystals, which is usually has a fan shape and it's polarizable, and the polarized light is showing this birefringent appearance here. So what does the ciprofloxacin crystal look like? So this is from the previous reports I found in the literature. So they, as similar to what we saw, they have this kind of purplish colored tinctorial pigmented crystal. And this one's actually giving you some kind of needle shaped here. And both of those crystals, they have this birefringent appearance and a polarized light. So it's important to rule out it's not like calcium oxalate or calcium phosphate crystals. So in the literature, they stained those 2 staining. So the alizarin red staining is negative, and also von Colza staining is negative in the crystals. So that's kind of helpful to rule out the other crystals, but there is no like a confirming test like to say, oh, this is ciprofloxacin crystal. It's more based on the appearance and the birefringent appearance and the polarized light. And also the clinical history is very helpful. So this is another paper. They list the ciprofloxacin-induced crystal nephropathy with some granular matrix interstitial nephritis. So this is what they look like. I apologize for the blurry of the images. It's from the paper. So A and B is showing some interstitial information, and then D is, as you can see here, is the crystals is probably surrounded by some like giant cells here, similar to what we see in our current biopsy. And so the table here is listing all the reports of the ciprofloxacin-induced crystal nephropathy. As you can see here, it's not that common, and it's usually in the elderly population. And I mean, it can also be seen in younger patients, but it's more like elderly population. And here, based on the limited data, it seems more in female patients, and the time of onset of symptoms ranges from 1 to 12 days. So they also mention sometimes the dose of the ciprofloxacin could be within the treatment dose. The urine pH, as I mentioned previously, is usually closer to neutral or it ranges from 5.5 to 6.5. And the risk factors, as I mentioned previously, is more like in the elderly population, like low body mass can be risk factors. So actually, that's the case was not the only one we saw. We actually encountered a similar case last year. So this is from a 77-year-old female. She has history of hypertension, hypothyroidism, and chronic hypokalemia. She was found to have ascites and watery diarrhea with normal kidney function. And then subsequently, she was diagnosed with diverticulitis. And she had metronidazole and Cipro at that time, and then developed decreased urine output and cloudy, bubbly urine, and was admitted to the hospital. So at that time, creatinine was 5.59. She also has nephrotic range proteinuria. So the clinical differential diagnosis at time is, broad, and they also think the AKI is more like pre-renal in the setting of diarrhea and low fluid volume intake. So what we see from that biopsy is there is also evidence of acute tubular injury, as you can see here, attenuation of the tubular epithelium, dilatation of the lumen, and also some cytoplasmic vacuolization. So similarly, we identified these purplish crystals within the tubular lumen. Is not very common. It's also very rare, like we were hunting for them. And when you look at those crystals and the polarized light, it's actually polarizable, give you these birefringence and a polarized light microscopy. Yeah, so the diagnosis for that time gave is acute tubular injury. There's focal global glomerulosclerosis, mild arteriosclerosis, and prominent arterial hydinosis. And we're also thinking the ciproflaxis in crystal nephropathy. The morphology of the crystals and the polarizable nature is kind of very similar, resemble the findings reported in the literature. So, Michelle, would you like to give some follow-up for our current case?
Yeah. So her creatinine, this is a graph of kind of her creatinine trend. So she kind of stayed around the 9s for a few days and then kind of started rapidly improving. And then she just got labs checked a few days ago. And her creatinine was down to 1.3. She was just treated with supportive care. Her lisinopril was held. She was initially given fluids. And then she followed up with Dr. Maeda yesterday and was doing pretty well.
Good, thank you. I think that's all I have. Any questions for this case?
Yeah, I've got one. I know, getting crystal nephropathy from a quinoline wouldn't be considered an allergy, but in a case like this, would you just kind of consider it certain circumstances, or is this something that you try to avoid this class of antibiotics going forward? That's really for everyone.
Yeah, so I think the important thing here is when we find these crystals, it's kind of helpful for us to know like the potential culprit for the the kidney function, like change and all these things, and it's helpful to rule out other possibilities or etiologies. Like for example, in this case, we were thinking the pembrolizumab, but it actually probably doesn't fit that, as is the pathology findings. Yeah.
Yeah, that's a great question. It was one I had too. Cipro was added to her allergy list, and kind of my thought was, if I were her, I probably wouldn't want to get Cipro again. So I
Right.
just
Yeah.
I just kind of I told her that, she doesn't have an allergy, but that if it would make
Just
sense
to
to not
avoid.
get that. Yeah.
Yeah.
So I kind of explained to her if she were ever in a really difficult situation where there were antibiotic questions and they were having a hard time choosing antibiotics, they could talk about that.
Yeah.
I might add a little different point, a little different view of that. Is that, I think this is a rare event. You have to take a little bit of leap of faith because we really just see very few crystals here. And I think that's largely due to the fact that, even the clinical presentation and definitely the biopsy, which is further delayed, that those happen distal to when the actual injury took place. The presumption is that there was a high concentration of Cipro and maybe a more neutral pH in the urine that led to just crystals forming and injuring the tubules. But those are pretty easy to correct and clear. And so we're just sort of looking at the leftover remnants from a prior injury process at this point in time. And I think it's a little bit challenging to figure out exactly what are the factors that led to this type of toxic reaction. And I think I don't know if it's necessarily something intrinsic to the patient's genome per se or their environment, and it might just be sort of an unusual combination of the Cipro plus some sort of event that led to the pH of the urine sort of helping it crystallize and precipitate and cause that type of injury.
Yeah, given the rarity of the crystals, it's probably not the obstruction of the crystals leading to all these, ATI and all these changes. When we see the crystals, it's probably saying that there are too much Cipro for at least for that patient, instead of the physical damage from the crystal itself.
Well, I think we're we don't know for certain because we haven't seen the actual acute injury process. That's probably a couple of weeks before this biopsy actually took place. So we're sort of looking at the remnants. So there could have been a lot of that at one time. And I think, thinking about, well, what if someone's on Cipro, what factors might lead to this? It's probably not very common, but the few people that get it do get pretty profound, but thankfully it looks like highly reversible kidney injury. I think the other instance in this patient that's something worth mentioning is that they are in this clinical trial and they're getting this experimental drug. And definitely one of the concerns of the oncologist treating the patient was whether or not this is really classified as an adverse event. And so I think based on the findings that we have in the biopsy, I think we can be fairly confident that this was not related to the experimental drug that the patient received, but was related to the ciprofloxacin treatment.
Yeah.
I'm just looking back at her UAs when she was diagnosed with the UTI, and the kind of UA pH was documented as less than 5 on the 16th, which was a couple of days before starting the Cipro.
Yeah, it's kind of fits with what have been reported in the literature. It's more acidic urine and also like
a question from Dr. Blosser in the chat, curious about whether there was a role of this EZH2 inhibitor in potentially treatment of the AKI indirectly.
Yeah, I think I think that there's nothing known about it, but as Chris mentions, it actually is, the drug has been associated with the opposite. It makes kidneys better. So I think that that was a with a new drug, there's always a concern that there might be something that we haven't experienced before. And so I think, documenting this to the best of our ability is good. I think, after looking at the biopsy, I don't have any concern about the drug itself causing this problem.
Any other question?
Okay, so if there are no more questions or discussions, we can give you guys 20 minutes back. So thank you very much for participating in today's conference.
Thank you. And thanks, Dr. Japian, Dr. Huang, and then the discussants, Dr. Carly, Sangavi, and Peng Chung. Great cases today. And then just a reminder for next week, we have a special conference. Neph Madness is being held at Harborview Medical Center in the R&T building. Details about parking and such to come next week. Everyone have a great weekend.